semester, y'all remember the hypothalamic, pituitary, adrenal, biofeedback, right? On the axis, okay? So pain stimulates that axis, okay? It releases that corticotropin releasing hormone, the CRH, which then activates ACTH, okay? Stimulating the cortex of the adrenals to release that cortisol, okay? Which then stimulates the adrenal medulla, medulla, to release that epinephrine, okay, that fight or flight response, which then stimulates that back to that posterior pituitary to release that antidiuretic hormone, which then leads to low urine output. Okay, so pain can lead to low urine output. The biggest part of that slide. Okay, so that's the pathophysiology around it. Okay, so when you have that decreased urine output, it can lead to mild, like acute kidney injuries, and we see that normally with a bump in their creatinine. Okay, which is why we always get a baseline creatinine in the beginning before they have the pain, if we can, or at least before surgery, so that we know, okay, this is either we haven't resuscitated them enough, or we're not treating their pain enough. Okay, normally resolved after a few days. Now the next one, the intravascular volume loss, okay, this can be due to third spacing, it could be to low resuscitation, okay, you have that vasoconstriction, okay, decreasing the flow to the renals because that's what our body does, it compensates, right? You want it, the body is going to continue blood flow to the major vital organs, the brain, the lungs, the heart. Okay, your renals kind of get shit up. Okay, so that you have low volume, vasoconstricts, trying to get the blood to the major organs, so your renals take a blow. That renin and then the angiotensin, then leading to aldosterone, okay, tells the body, I want to resorb or keep that fluid as much as possible, meaning low urine output, okay, leading to that mild AKI. You're going to see a dilute or a low serum sodium because your body's systems, you're compensating, you're trying to keep in that water, meaning your sodium is actually the same, but you have more water being retained, meaning you're not producing enough urine. Okay? Again, resolves in a few days. We sometimes can give them, the more we kind of plump them up and give them that fluid, we do have to be careful because if you are third spacing, the more fluid you give, the more third spacing you have. So in this, we'll learn in the next kind of lecture, we can give other things like albumin to kind of keep that intravascular fluid level up. Okay? All right. So, two things, post-op endocrine issues that we need to be aware of. If they are on long-term steroids, okay, we can actually cause a Addisonian-type crisis if they stop it cold turkey, right? So can lead to hypertension, hyponatremia, and hyperkalemia. So if we're on steroids, we need to know so that we can give them those stress dose steroids if we need to, okay? And that table kind of just goes over like how we actually administer. I'm not necessarily going to test you on the chart. It's just good to know how to like dose out their steroids to help with that stress dose. Okay. And then for the thyroid, we do want to try to have patients be euthyroid, meaning their thyroid is under control. Okay. If they're hyperthyroid, we could cause a thyroid storm. If they're hypothyroid, we can cause cardiac failure. Okay, so trying to get these people into a normal thyroid level is pretty key before surgery if we can help it. Okay, blood disorders. Knowing if they have any blood disorders beforehand is really important. Okay, they may not know that they're hemophiliac, but you know, if they have bleeding in their joints, deformed joints, they're swollen, they're painful. You may see like deep vein thrombosis if their whole leg is swollen, red, and painful compared to the other one. Okay. Medications, again, warfarin, aspirin, NSAIDs, we want to normally stop those about a week before. If there's a cardiac stent present, like we talked about, the cardiologist and the surgeon must discuss the case so that we can determine on, you know, when to stop the warfarin, or maybe we need to switch them to a DOAC, or maybe we need to switch them to Lovenox pre-surgery. Okay. And we already talked a little about the liver disease and the clotting. We'll talk about the TEG in a minute. And then any particular rashes that they could get, we want to know their platelet count. We want to know their bleeding time. It's pretty rare to have blood dyscrasias without really knowing, but if the family history supports it, then it's good to know. All right, knowing about the TEG. A lot of hospitals do not have TEG machines. Okay, a thromboelastogram. This is a very quick, real-time monitoring of coagulopathic patients. Okay, like I said, a lot of hospitals. I've only worked at one hospital so far that has actually had it. We can look at this graph, and it's on the next slide. Basically, to say, are they hyperfibrinolytic? Are they have too much platelets? Do they have low platelets? What do we need to do next in order to get them back into a normal clotting pathway? Okay, so this is the different type of charts that you'll see. Okay, this first one is kind of normal, right? You'll have the R, the K, the angle, all this stuff. I'm not going to have you guys really know this, just know that it exists, okay? And that if you have like a long R, they may be hypercoagulable, like they may be on anticoagulants, or they may be hemophilia, or if they have a low R but a long like bell, they may be on platelet blockers like aspirin. Okay, so it just what the bell and the R looks like it'll tell us, okay, we need to give them platelets, we need to give them FFP, we need to give them cryoprecipitate or vitamin K or whatever, right? So this is a very in-depth, very quick, real-time thing that we can use if your hospital has it. Okay, but again, not a lot of them do. It's very, very expensive. But this is just good to know. Okay. All right, nutrition. Proper nutrition is really, really important for wound healing. Okay. If we suspect that somebody is cachectic or anorexic or they really just look malnourished, we'll get a pre-op albumin and a pre-albumin. You can also get a pre-calcitonin, but that's can be for nutrition and for infection. So albumin, if it's less than 3, kind of suggests chronic malnutrition. Okay. Pre-albumin, if it's less than 16, suggests acute malnutrition. Okay. So someone who is chronic malnourished, you have cancer patients, you have someone who has, let's say, mesenteric ischemia. Every time they eat, they get pain because their gut has little clots and it's not getting enough blood flow. Right? They're not going to eat. So they're chronically malnourished. Okay, someone who's acutely malnourished, say they have an appendicitis and they just haven't been eating, it's just a low brewing appendicitis and they're multiple days they're just not eating, or they have the flu and they haven't eaten, they have the stomach bug, whatever, right? It's an acute malnutrition. We're looking at pre-albumin. When we're looking at chronic malnutrition, we're looking at albumin. Fluid management and blood volume, we'll talk a lot about this in the next slide deck. But we really want to try to correct physiological abnormalities prior to the surgery. Okay, whether or not we need to give crystalloids or colloids, like the albumin that I talked about, whether or not we need to give blood or blood products. We need to try to correct that coagulopathic, right? If their INR is through the roof, we may need to give them vitamin K if they're on a DOAC. and they're bleeding, we may need to give them the reversal, which can be very, very expensive. Okay, maybe we just need to give them cryoprecipitate. Right? TXA, who remembers what TXA is? Transamic acid, what does it do? Right, so it doesn't help you clot, it just tells your body, don't break down the clot I'm making. Right, so TXA is very, very important in trauma. We want to try to correct those acid-base imbalances. If the pH is way off, the body doesn't like it. Okay? And then repleting electrolytes. We want to try to achieve this normal level. These are the normal levels that we try to achieve. So magnesium of 2, a phosphate of 3, and a potassium of 4. Okay? The gut likes this. If it's out of these ranges, you can sometimes anticipate maybe having an ileus, meaning the gut is stunned, it doesn't want to work. It loses that ability to peristalsis food. Okay? So when we get into the next lecture, you'll know, like, we'll talk about these things being extremely important and trying to, we don't say replace, but we're repleting them. Okay? All right. Things to consider to all surgeries. So this is just a generalized pre-op kind of slide. We want to take out all jewelry. We want to take out their contacts. We want to take out their dentures and give them to a family member if we can. Okay. We always do a team steps prior to every operation. This kind of goes through who's everybody in the room, what operation are we going to do, what limb we're doing it on, right? The 5 R's, 6 R's, okay? Making sure that the informed consent is signed, right? Any other consents, blood consents that are signed. And then any local hair removal we'll do after they're asleep. We normally do it with a razor, electric razor. Okay? So just some things to continue. Good, sir. All right, any questions on that? No? All right, let's move on to, we're gonna do fluids, electrolytes, and nutritional support. Let me know when everybody's up. You good? Good. All right. Those are your objectives from the syllabus. Caveat. I realized yesterday that the syllabus took out nutrition. We need to add nutrition back in, so it's slightly different, but the next iteration of syllabuses will see that. You will see this. Okay? We have to talk about nutrition when we talk about surgery because we need to, feed them. All right. So, volume, electrolytes, they all play a role. Okay? 60% of our person's body mass is water. 2/3 of that water is inside your cell, or what we call intracellular, and 1/3 is outside of your cell, extracellular. Okay? Normally, when we say extracellular, you have the interstitial fluids, and you have your blood volume, like your plasma. Okay? So it's not inside your cells. Sodium lives outside your cells. Okay? Potassium lives inside your cells. Why do we need to know this? Because the relationship on where they are plays a big role on where the fluid shifts are going to happen and how you tell if it is where the fluid shifts are going to happen. Okay? Surgical patients are really at a high risk of electrical imbalances because anesthesiologists, CRNAs love to give fluid-bearing cases, and we may overfluid them, and so we may see these electrolyte imbalances pretty routinely. Okay, so nice little picture, kind of give you an idea of female, male, where our fluids are. Okay, and then intracellular, you have more K intracellular, and you have more sodium outside. All right, osmolality versus osmolarity. I know, back to biochem. I swear this is the only biochem. Okay, only biochem. So osmolality, okay, you have a solution, okay, and it is, the solution is the solute plus the solvent, so water plus solute, okay, whatever that solute is. And we express that as the number of particles, or solute particles per kilogram. Then we have osmolarity, which is the solvent, the water, okay, expressed as the number of solute particles per liter. So it's a weight. Okay? Osmolality is more accurate. This is what we use when you order a osmo, okay? We're actually ordering osmolality. We're trying to figure out how much solute is in the water. Does that make sense? Kind of. Okay. We use osmolality because it doesn't change due to temperature. Osmolarity does. Okay? So when you're in blood, we don't want it to change due to temperature, so we use osmolality. Okay. Tonicity. Okay. This is the solution, so that solute plus water, the ability for it to move between spaces. Okay, or across that cell membrane. Isotonic means same concentration on both sides. Cells are happy. Okay. Hypotonic means loss of concentration. Okay, so you have a loss of, say, sodium, okay, and water rushes into that to try to even it out. Okay, but unfortunately the cell doesn't like that because now you have too much water in the cell and the cell swells. Okay. Hypertonic, meaning sodium got into the cell, or water dropped in the cell, and now you have too much of this solute, okay, too much of the particle in the cell, but not enough water, and so, no, other way around. Water gets pulled out. You still have too much concentration, but you get what I'm saying. The cell shrinks, okay, trying to get that concentration to water even. Okay, the body's constantly trying to get that even concentration of water and solute. Okay, I swear this is going to become important in a minute. Okay, so relationships between sodium and water. Okay, sodium can't go back and forth over the cell membrane. Water can. Okay, so the concentration of sodium isn't going to necessarily change. It's the water that's going to change, whether it's going to shrink or swell. Okay, but sodium does freely flow between the capillary wall, so out into your capillaries, into your bloodstream. Okay, so this is where like third spacing is. Okay, if sodium leads into your bloodstream, the water goes with it, which leads to a low volume capacity. Like it decreases your intravascular fluid. Okay. Okay. So, what does that all mean in terms of the body and why we need to know that? Okay. That's more like review. Okay. So, hypovolemia, meaning low concentration of volume within the blood vessels. Okay. You still have the same number of concentration, but not enough fluid. Everybody still awake? Okay. So what does our body do to try to fix that? Okay. It releases that aldosterone to try to pull that fluid back in, like we talked about in the last slide deck. Okay. You're going to try to conserve whatever body fluid we have extracellular to pull back into our blood vessels. Okay. So what does this result in? It results in a low urine output that's very, very concentrated. Okay. You're still peeing out the same number of solutes. Okay. Same number of electrolytes and all that stuff, but the body's pulled back the fluid, so it's very concentrated but low amount of urine. Okay. We'll talk about FeNA in a minute. But this kind of FeNA will tell you whether or not it's pre-renal, intrarenal, or post-renal. but we have a few slides on that, so I'm not going to talk about it too much right now. What milligram or milliliter per milliliter per kilogram per hour urine is normal? Our bodies like to produce about 0.5 of a milliliter per kilogram per hour. Okay, so if you are a 70 kilogram person, you're most likely going to be making about 45 milliliters per hour. Okay. If it's less than that, then you have oliguria. Okay, so knowing that person's body weight is really, really important when we're trying to talk about urine output. Now, there's other ways to lose volume other than just hypovolemia. We have insensible losses, okay? So we normally lose from our skin and our lungs, okay? Because our lungs have hydration, humidity type deal, right? So we lose about 600 milliliters per hour by just sweating and breathing. Okay, we take that into consideration when we're doing our maintenance fluids. Increases significantly when you have a fever or critical illness, right? You're sweating more, you're breathing more, okay? And then GI tract losses, about 250 milliliters per hour, or per day, okay? And that's, and it increases with vomiting and diarrhea. Now, normal, like I said, maintenance doses are already taking this into account. This comes into play when we need to replace or resuscitate. So, are the kidneys doing their job? A gold standard of knowing what if they are or not is we do a renal electrolyte excretion test. That is a 24-hour urine test. They pee in a jug over 24 hours. We send that to the lab, and then they do calculations on that. Okay. But it's very slow, sometimes inaccurate. Okay. So the better method that we use is the fractional excretion of an electrolyte. So FENA. Okay, we can do this on any spot urine that they give us, any random urine. Alright? So really it helps determine the cause of what our urine injury is. Again, pre-renal, intrarenal, or post-renal. Okay? If it is a low FENA, so less than 1%, it is pre-renal. Okay? So what is affecting the kidneys before the urine gets to the kidneys, or the blood gets to the kidneys, that's causing that FENA or that urine output to be low? Okay, that's blood loss. Okay, that's pain, that's infection, like septic, not kidney infection, but sepsis. Okay, if they have low output heart failure, okay, the blood's going elsewhere. The blood is being shunted away from the kidneys before it gets there. Okay, if it's above 2 or 3, post-renal. Okay, meaning what type of post-renal disease can you think of that might necessarily decrease the amount of urine that it leaves the kidney?
Stones.
Obstruction, stones, absolutely. Okay, if the urine can't leave, then you have a post-renal. Okay, intrarenal would be more so between 1 and 2. That's where it gets a little gray. That's when you have the ATN, the acute tubular necrosis. There's actually a problem inside the kidney. Okay. All right. So when you do your FENA, getting the percentage, okay, you have to get urine lights and you need to get a CMP. Okay. In terms of urine lights, you need to make sure you have your urine sodium and urine creatinine, and you need your serum sodium and serum creatinine. Okay, so you take your urine sodium, times it by your serum creatinine, divide it by your urine creatinine, times your serum sodium, and then times by 100. Okay, here's an example. I have an example for both pre-renal and post-renal. Okay, so you get your urine lights, you get your CMP. Okay, your urine sodium is 50, urine creatinine is 100. You can read, so you do the math. 0.36%, less than 1%. It is a pre-renal issue. Okay? Meaning your kidney is trying to hold on to or conserve sodium, trying to bring in that water to bump up your intravascular losses. Okay? Post-renal, you do the math. So these are potentially your acute tubular necrosis, but most of the time if it's higher than 2, higher than 3, it's most likely going to be your obstructions and that kind of thing. Okay. All right. Now, perioperative kidney injury, very, very, very common. Okay. The old way that we used to do this is fluid resuscitation, liberally. It really hurt people, has significant volume overload. Okay, so now we do judicial fluid resuscitation. Okay, it's protocol based. It really depends on your weight and how much insensible losses are you having. Okay. When you have a pre-renal insult, treatment is fluids. When you have a post-renal insult, treatment is fluids. As well as if it's an obstruction, you're trying to alleviate that obstruction. Okay, you can't just add fluids and fluids and fluids without resolving that obstruction. The fluid's not going to go anywhere. Okay, so pretty easy, right? Treatment is fluids either way. We're trying to filtrate that kidney to get whatever is offending out of the way. Okay, so a lot of slides just to say treat with fluids, but judiciously. Okay. All right, this is important. I want you to look through it, but I'm not going to test you specifically on this because there's a lot of information here, and it's kind of an overview of what this entire slide presentation is. Okay. All right. So, how to spot dehydration? How to spot this before it becomes an issue, before it actually hits the kidneys. Okay. If you have somebody who is tachycardic, hypotensive, if they have orthostatic hypotension, okay, the mucous membranes are dry. Look in their mouth, their tongue is dry. Okay? They have decreased skin turgor. Who can explain that? Yes. Yes. You tent the skin, and if it stays up, that means they have decreased skin turgor. Okay? It should go back to elastic, right? If it's nice and elastic, you're nice and hydrated. If not, you're pretty dehydrated. Okay? And if your urine specific gravity is over 1.020. Okay? So reasons to start IV fluids, they're volume depleted. Okay? They're dehydrated. You see all of these things. They're not producing enough urine. They're going to be NPO, meaning nothing by mouth, more than 12 hours. Okay? It's a planned elective surgery and they're coming in the night before, or they're in the ER with appendicitis and they're making them NPO for their surgery the next day. Okay? Put them on a maintenance fluid. We need to maybe increase that maintenance fluid because of insensible losses. They have a high fever, they're tachypnic, they're breathing a lot, right? Or if they have burns, which we'll talk about. Okay, this is not the only time you will see this chart. This chart will come into play more times than not. Okay, you need to know the classes of hypovolemic shock. Okay, so class 1, they have very minimal blood loss, less than a liter. Okay, their pulse rate the body's compensating well. Okay, your heart rate's normal, less than 100, your blood pressure's normal, you're not having any altered mental status, they may seem a little anxious, okay, but nothing crazy, and their urine output is still normal. Once you get to class 2, okay, so about 1 liter to 1.5 liters, the biggest sign you're going to see is their heart rate goes up. Okay, your body's trying to pump more with less. Okay, so your heart rate goes up, but it's normally a very mild tachycardia, just above 100. Your blood pressure may be minimally decreased. Okay, so instead of 120, they may be 100, but it's nothing that is crazy. Okay, they're still compensating. Class 3 is when we really start to see the decompensation start. Okay, their heart rate goes up to 2 or over 120. Their blood pressure is significantly lower, so in the 80s. Okay, your pulse pressure is narrowed. Now you're starting to see the kidneys take a hit. Okay, that biofeedback starting to take into account, and your body is starting to try to really absorb that fluid back intravascularly. Okay, so your urine is decreased, and now they're anxious and confused, meaning there's not enough blood flow going to the brain. Okay, there's not enough blood to get to the brain. When you're at class 4, greater than 2 liters, how many liters are in the body?
5 to 6.
In a big adult, yes, 5 to 6. In me, probably 4 to 5. I'm tiny. Okay? So, if I lose 2 liters or more than 2 liters, that's more than half my blood volume. I'm going to be probably very tachycardic, over 140. My blood pressure is going to be shit, less than 80. Okay? I'm going to be very confused and lethargic. And or, speaking of, I feel like I'm going to die. We call that the doom speak. Okay? They're talking about I'm going to die. I feel like I'm going to die. Okay? They have very minimal urine output. Okay, that's stage 4. That's class 4. Okay? If I give you a scenario, I'm going to need you to be able to tell me what class they are. This is extremely important, especially for when you triage downrange. You must be able to do this very quickly. This is why they make it very easy in terms of things that you can observe and or take very quickly. Okay? Alright. Hydration status measurements. So traditional vital signs, sure, but they don't really correlate really well sometimes to actual intravascular volume. Okay? So the pulmonary response Gantz catheter, or pulmonary artery catheter, they place it into the central venous system, into most likely through the femoral artery and up. They can do it through the radial, just depends on what they're going to do. But basically, they float it into the heart and into the pulmonary artery. Okay, this is an intravascular, intracardiac type of monitor that really measures pulmonary pressures. Okay, it can measure central venous pressure, pulmonary capillary wedge pressures, and the right ventricle systolic volume. Okay. The only people who use this now are cardiac surgeons. We do not use this. I have not seen any medical or surgical ICU attendants ever use the Swan scan catheter. Okay, so if you're in a cardiac ICU, a CCU, you're probably going to see this. Cardiac surgeons, CT surgeons love to use this still. I don't know why. But I'm not a CT surgeon. What we use is called the FlowTrack or the Vigileo. Okay? This gets hooked up to the art line, your art line, either in your radial or your fem. Okay? It is this picture down here, okay? Basically it tells us our SV volume, our capillary pressures, our CV pressures, our cardiac output, like all of it. Okay? So this is a way better, slightly less invasive way of putting a catheter in your heart, right? We're just using a peripheral arterial line to get all the same numbers, which is why medical and surgical ICUs that I've worked at don't use Swan scan catheters anymore, because the complication rate for those having a catheter in the heart, right, it lowers that complication risk. The other way we can measure hydration status very, very quickly is ultrasound. You will learn this in EM. Okay? The IVC is a great, great way of doing a very quick hydration status of intravascular volume. If your IVC is nice and plump, doesn't really compress with respirations, you're pretty well hydrated. If it collapses every time someone takes a breath, you are probably very dehydrated and or have volume loss. Okay, so it's a very quick and dirty way of finding someone's hydration status. All right, laboratory testing to know if they're hydrated or not. I think we kind of talked about this a little bit yesterday, pre-op, post-op, and recess. Pre-op's really tailored to what you need, okay? Post-op, we normally do a CBC, a CMP, we'll do a coag panel, and plus or minus a arterial blood gas. Okay, this is to measure what we started with, or to compare to our baseline that we took pre-op. Okay. If we have someone who has a severe trauma or a major sepsis, we absolutely will add on the coag, ABG, and we may do a fibrinogen to see if they're clotting efficiently. Okay. No, the biggest thing on this slide, hemodynamically stable but critically ill, the hemoglobin threshold for blood transfusion is less than 7. Okay? Normally the hematocrit is about 21%, but if your hemoglobin is 7 or less, we're most likely going to give you a transfusion if you accept it. Okay? Now, those thresholds do move depending on your other comorbidities. Cardiac surgeons will say if you're a cardiopath, their threshold maybe if it's less than 8, maybe sometimes less than 9, you may get a blood transfusion. But for normal, healthy patients, if your hemoglobin is less than 7, normally you win a unit of blood. Okay? How many units of blood should if you give them 1 unit of blood, 1 unit of packed red blood cells, how much do you think your hemoglobin is going to rise? 1. Okay, so if you have a hemoglobin of 6.9 and we give you 1 unit of packed red blood cells, your next CBC should show a 7.9. It'll go up by 1. 1 unit to 1 point. Does that make sense? Okay.
Regardless of size versus
What's that?
regardless of the size.
All right. So, you have a patient. What fluid rate are we going to pick? Okay, there's 3 different ones that we can pick. There's maintenance, there's replacement, and then there's resuscitation. Okay, maintenance is someone who may be slightly ill, they have no real and sensible losses, they're not vomiting, they're not diuretic, or having diarrhea, okay? But they're maybe a little bit dehydrated or they're going to be MPO for more than 12 hours. Okay, the normal rate for adults is 30 mils per kg per day. Okay. So here we could also add dextrose. Okay. And we can also add potassium. Maintenance fluids only. Okay. Replacement, these are your people who have increased insensible losses more so than the normal. Okay? So think maintenance plus. You're still doing the 30, but you're replacing those insensible losses. Okay? So say they have an NG tube in and they're putting out 2 liters from their belly, from their stomach a day. Okay? That's how much is it normally put out a day? From your gut? 250? Right? So that's a lot more. So we have to replace that fluid loss. Okay, so we're going to take that 2,000, divide it by 24, and that is, you're going to add that to your normal maintenance rate. Okay? Now, you can use 2 different fluids for this. You can still use your maintenance dose of LR or normal saline with that dextrose and potassium, and then add on LR of 200 an hour to replace. You can do that. Or you can just change completely to LR and say I want 120 mLs an hour until the replacement is caught up. Does that make sense? Sometimes it's a hard concept. Okay? Now we go into really sick patients, okay? We're in resuscitation, okay? You're most likely going to use blood. These are the people who come in for trauma, they're bleeding, okay? Blood in, or if they have blood out, you put blood in. If they are septic or have a hypovolemic cause other than blood, we're normally going to use pretty much whatever we have, LR, NS. Plasmolate is great, it's the most evenly kind of condensed or concentrated fluid to our natural body as really we can. And then albumin if we need to control those third space losses. Okay, so what do we use maintenance fluid for?
Kind of sick.
They're MPO, they're just dehydrated, right? They're not losing anything over and above what they normally have. What is replacement?
Sicker.
They're sicker. We're trying to give them what they lost via diarrhea, vomiting, okay, from their NG tube. Maybe they're burned and they are losing fluid through their skin. Okay, so that's maintenance plus, right? When you think of replacement, maintenance plus whatever they're lost. Okay? And resuscitation, really sick. Those are our septic patients, those are ICU patients. Okay? They're gonna be getting a lot more fluid because they're losing a lot more fluid. Okay? This is a concept you must understand. There will be test questions on what type of fluid and how much fluid. Okay? Alright. So, initial fluid resuscitation. Okay? So resuscitation. They're really sick. Okay? We're either going to use warm crystalloid solution, normal saline, or lactated ringer. We like lactated ringer more because if they're already having an acid-base imbalance, okay, NS can cause hyperkalemic metabolic acidosis, so they can make their acidosis worse if we use NS with a lot of NS. So most of the time we're going to use LR for resuscitation if we're not using blood. Okay? And then blood transfusions for active hemorrhage or profound anemia. Okay. All right. Now we're into maintenance type fluids. Okay? So we already talked about LR, using resuscitation due to hypovolemia. Don't necessarily like LR-NS for maintenance or replacement, but you can. Okay, when we're talking about maintenance, we really like this: a D5 half normal saline. Okay, so that's 5% dextrose in a 0.45% sodium chloride solution. Okay, we will normally add potassium to this. Okay, maintenance. Okay, we do not use this for resuscitation. We do not use this for replacement. D5 half normal saline is what we use only for maintenance. Only for maintenance. We cannot use it for other things. Okay. If it's very common that we may do both. Like if they're already on the D5 half normal saline with potassium as their maintenance dose, and like I said, they have an NG tube post-surgery, and then we have a lot of losses for that NG tube, we may add on LR at whatever that loss is. Okay? Or we may stop the D5 half normal saline altogether and just go straight to LR until their losses are caught up. Okay? There's many different ways to skin a cat. Okay? Any questions on this? Cool. Alright, so choosing the correct fluid. We already kind of talked about this a little bit. Okay? You'll see this first line, NS, so normal saline. Okay, you have a pH of 5.5. That's pretty acidic. Okay? Your sodium, what's the normal body sodium? What's our normal sodium level in the body? 135 to 145. So is NS hypernatremic, right, at 154, okay? Chloride, hyperchloride, which causes that metabolic acidosis if you give too much of it, okay? But you see LR has a little bit better pH, it's a little acidic still, but not too bad. But their sodium is actually within or just less than our normal sodium, okay? And our chloride is a little bit better to where we're supposed to be too, and it has a little bit of potassium in it. Plasma light is what I like the best. If your hospital has it, it is most closely aligned with what our normal body physiology is. Okay, I've only worked in one hospital that has it that fancy. So when you have people who are, when you're trying to pick a fluid, sometimes we only have NS. Sometimes we just have to deal with it. Okay, but if you know what's in it, then you'll be able to choose a little bit more intelligently. Okay. All right. So you have a 23-year-old female patient presents to the emergency department with nausea, vomiting, diarrhea for 48 hours. Her heart rate is 155. Her systolic blood pressure is 80. She's tachypnic to 24, but still oxygenating while ever a mayor of 97%. GCS is 14 because she's confused. Her pupils are 3 millimeters and equal, round and reactive. Capillary refill is greater than 2. Which of the following intravenous fluid prescription strategies is most likely to be utilized initially in this patient? Who wants 1? Okay, the replacement, okay. 2. Okay, 3, 4, 5. Okay. Seek extra, sure. Seek an adult, sure. Okay, so what class of hypovolemic shock is she in? Right, her heart rate is greater than 140. Her blood pressure is shit, and she's confused. Okay, we don't know what her urine output is because she just got here, but I would guess it's probably low because she's vomiting and diarrhea. She's probably dehydrated. Okay, so if she's class 4, do you think she just needs replacement? No, she needs resuscitation. Does that make sense? Okay, if she was a class 2, maybe we do replacement. But her body is telling us, I'm in trouble. If we don't do something quickly, she's going to spiral worse. All right, what time is it? Break time. Break time? All right, 10 minutes.
Patient, that would be my bad.
What's that?
So I'm your patient.
You're gonna be patient? Wait. Okay.
gotta go shower after that, huh?
That's Bryson Gibbs.
Okay. I've seen the scientists for the charities. I make no money after training my people. What's up?
So,
I don't know. I have to finish right this time.
okay, if you have somebody who goes to 6 months or more, okay, so the only replacement for blood is because it's causing more, well, the we're gonna go, the triad is. Yeah, you're diluting it more, you're not fixing it with your. You're diluting those microfactors. So they can't actually work.
I mean, I might. No, I actually might.
Who's that person?
I was like, I don't know. That's why it's over. Yeah, that's right.
Yeah, the class that I went through, like I already knew that was not one of the next. Yeah, I know, I'm trying, but, I didn't have enough, I really thought I was having more time.
This feels so good.
I'm trying, yeah, I'm definitely trying.
I'll remember next time that you,
No one there's nothing wrong.
that would help the situation. You're welcome.
Not disrespectful at all. I'm gonna go back and call the cop, like, what the fuck? I'm wondering where this building
What type of test did you, next for there's the
Was it better than the first one? Why is that on Netflix? I cannot. Why would you? I took my watch the movie. Oh my god. Mary hasn't watched. Oh,
That's
my,
a weird.
that is a crime.
Top don't ever get someone formation. That's their kind of going up.
There's no way. That's like,
I don't have a Hulu. It's not on Netflix.
it's on YouTube probably.
Oh, it's in a world area.
It's not long. I was a teenager. It was one of those movies that were like. I was debating to watch the second one just to see like how it works.
Theater right by here.
Wait, this is the one that was.
I wanted to and then I was gonna go to Turkey, but I didn't get there till later.
Yeah.
And then you that theater seems a lot of kids from the high school that go there all the time. Because as soon as I drive, we go eat or like we're like don't even get lost. Like don't even go.
Yeah, but because if you go up $100, it's still 10%. It's cool. Well, and that one guy has a crazy car. You? I don't see them being like. I mean, you see the new prosecution. It's like all the world. It's a. I forget what they call it. It's like almost rainbow tag teams, but it's like more futuristic. It's like a new classification. It was like high school. It's a new class for 30. One of them is up next. They take over all of them.
The captain went to,
I think he's like still too young. Let's go.
Yes.
Yep, let's go.
Yes, I see head shakes. Okay, cool. All right, so resuscitation. So what is massive transfusion protocol? So normally you have to have at least 6 units of packed red blood cells, 6 units of whole blood, okay? To really be called a massive transfusion, okay? If you just give 1 or 2, that's not massive, okay? Normally it has to be over 6. If we're using blood products, okay, meaning red blood cells, plasma, platelets, we try to do a 1-1-1 ratio, the golden ratio, okay? Sometimes that's not always achievable, but we try, okay? And for platelets, 6 packs come to 1 unit, okay? So it's a little weird for platelets because they're frozen, so it's one of those things that you normally have to give. When you get platelets or when your nurse gives platelets, they're 6 to 1 unit. they're small. Okay? Alright, so we're trying to limit the exacerbation of the lethal triad. So lethal triad is hypothermia, acidosis, coagulopathy. Okay? Meaning too much acid, too cold, they're not clotting right. Okay, that's the lethal triad. So we try to avoid that, so we don't do excessive crystalloids anymore. Anybody who's been doing trauma for, I don't know, a few years, probably learned back in the day that the initial treatment was 2 liters of crystalloid. We no longer do that. Right? Even now, they're on our ambulances, we are trying to put whole blood so that they don't have to use crystalloid. It worsens that coagulopathic pathway because all you're doing, so you have not enough blood, okay? And now, oh great, we're gonna try to increase the volume of your intravascular space, but you're still decreasing the concentration of what's left. Okay, so you're decreasing the concentration of your clotting factors, like all of it, right? So it does not do well for the patient to get crystalloids initially. Okay, blood out, blood in. What we really love, the gold standard, is cold stored low titer O whole blood. Okay, that is our fluid puts. Okay, low titer, meaning it's been screened to not have as many of the weird antibodies that could potentially come with other whole blood. Okay, we're like O. Okay, because it's a universal donor, and whole blood because it has everything. Okay, we don't have to use that 1:1 ratio. It has everything. It's whole. Okay, so we don't have that pre-screened. Low titer, cool. If we have to, we'll use the ratio, okay, plasma, red blood cells, and platelets. If we don't have platelets, then we'll use basically whatever we have, okay? But the gold standard is that low titer O, okay? So O negative packed red blood cells, cool. That's what we only have. Why do we want the negative?
No RH factor.
RH, right? That's the RH factor. Negative RH, okay? Do we want to give a positive RH blood to a negative RH female?
Bad day.
That's bad news, right? That'll potentially harm any future pregnancies that woman has. Now, if that patient is a O positive, we can use it, okay? But we want O negative. Let's see. For whole blood, we really like to give it screened. Okay. If we need to, we can do the walking blood bank, the Valkyrie program. Okay, I'm not going to go through the Valkyrie program. I think EM does a better job of that. But it's available. Okay, knowing what that program is extremely important. We don't necessarily have walking blood donors in the civilian world. Okay, normally they just get blood from the blood bank from already pre-screened patients, but in the military we have a lower incidences of like HIV and some of the other nasty stuff that can be transmitted through blood. So our blood banks are a little bit easier to do walking versus civilian. Okay. So fresh frozen plasma, that's the one that has the clotting factors, but it takes about 30 minutes to thaw. Okay. 1 unit of platelets can raise the platelet count about 25,000. Pretty good. Okay. We normally reserve giving platelets unless they're actively bleeding or they have a platelet count less than 50,000. Okay, it just depends. I've had patients who've had a platelet count of 30, but they're not actively bleeding. We're not going to surgery. We kind of hold off as much as we can. Okay, just depends. All right, additional fluids that we use in resuscitation, we have colloids, albumin. Okay, we do not use this in acute resuscitation. Do not use this in acute resuscitation. This is more for that replacement, or they're been in the hospital for a few days, or noticing a huge increase of their third spacing, and we want to try to bump up their intravascular fluids, but giving more fluid, more crystalloids is just going to worsen their third spacing. Okay, albumin is a thicker molecule. It doesn't go through that capillary membrane. Okay, so it stays intravascularly. Okay, but we don't want to give this in resuscitation, in acute resuscitation. Hypertonic saline. Okay, this is when basically you have that 0.9% normal saline. Okay, now it's 3% or 27% sodium chloride for the solution. Okay, there's only a few, like 1 or 2 reasons why we do this. Okay, if someone is in a hyponatremic crisis, okay, they're seizuring because their sodium is so low, we can give them a bolus, but they have to be seizuring. They have to be in an active seizure, okay? Or if they have a head injury and we're trying to decrease that intracranial pressure, we can give them a bolus of sodium, basically. Okay? The only 2 reasons why we use hypertonic saline. All right. Medications used. We have DDABP. Okay, so this is if you have somebody who has factor 8, so von Willebrand's, this activates more that clotting pathway. Okay, so DDABP, if you have somebody who's not clotting fast enough, you can give them DDABP. Okay, they have platelet dysfunction. Okay. We use this also in people who have DIC, disseminated intravascular coagulopathic. Okay, we'll talk about that later. Cryoprecipitate. This has a lot of your clotting factors, so it's a little bit like plasma on steroids. Think of it that way. Okay, has a vitamin. It has your factor 8, your fibrinogen, fibronectin, factors 8 and 13. Okay. FFP also contains all these solubles, but it's just better. Sometimes this is what we need when we need to get their clotting factors up versus getting them volume. Okay. We have aminocarpic acid. It's an antifibrinolytic, so it strengthens the clot. I haven't used this one as much because now we have PXA. Okay, so the transacemic acid, again, antifibrinolytic clot. It strengthens the clot. If we give it within 3 hours of the injury, it has been proven that it does benefit. Okay, it can strengthen that clot. Now, if you get it after 3 hours, it's been proven to cause other complications. Okay, so only use within the first 3 hours after injury. All right. So 75-year-old lady is admitted for a planned elective knee replacement surgery the next day. She has long-standing hypertension for which she takes amlodipine. She has no other medical problems. Lab parameters are all within normal limits. She's placed on intravenous fluids. Her weight at admission is 80. Which of the following is the correct choice and rate per hour? First off, what type of fluid do you want to give her? Out of these options, normal saline, and that one is the top 2, 0.9. Okay. She weighs 80. Are we doing
25.
maintenance, replacement, or resuscitation? Maintenance. So that's 30 mLs per kg per day. Do math.
2,400.
Who wants what? What? So 100 mils per hour of normal saline. I would know how to do this for the test. Okay. Plus, you need to know how to do this for your day-to-day. You know, if you're in a clinic and you need to give fluids or something. In phase 2, you'll absolutely have to rate for your maintenance fluids and your replacement fluids. Okay. So be able to do that. Any questions on this? Cool. Moving on. All right. So how to track your hydration status? We put in a folio. We track their urine output, okay? Their urine output is our number one best way to track how hydrated a person is, okay? We put an indwelling catheter into their bladder, okay? Indications, so we don't just put it in everybody, right? If they are not demented and they can follow directions and they have use of both arms, we can put in, we can get, you know, a urinal, okay? But if we really want to track their ins and outs accurately, okay, we put in a Foley. If they're going to be immobilized for a long time, say they have a hip fracture, we're not going to be able to get them out of bed, or a femur fracture or a pelvis fracture, right? And they can't put any weight on their legs because of their pelvis fracture, most likely they're going to earn themselves a Foley, okay? Or say they have a huge skin defect, right? They have a decubitus ulcer that's weeping and we want to try to keep it clean, okay? We don't want them sitting in urine. We may put in a Foley to help keep that area clean. Does that make sense? Okay. Or if they have a neurogenic bladder, with those you'll see with spinal cord injuries and that and the like. Most of the time though, after a while, that would be more so for the acute neurogenic bladder. Most of the time we can transition to what we call a straight catheter. Okay, it means it's not an indwelling, but because their bladder doesn't receive the signal, we can put a catheter in every so often. So every 4 hours, we put a catheter up, they pee, and then we take the catheter out. It's not, we don't leave it. Okay. Complications. We can cause infection. Okay, we can cause UTI, we can cause urosepsis. We can cause urethral injury. Okay, for that, you know, 80-year-old with BPH, right? If we really try to stick it down there and it's not really going because the hole is way tinier than the Foley catheter you're trying to place, you're gonna cause injury, you're gonna bleed, or they're gonna bleed, okay? You're gonna have clots, it's not gonna be very pleasant for that patient. We don't numb up patients to do this, we just use lube. Okay, so you can cause urethral injury if you don't know what you're doing. Why do we do it? Why do we put a Foley in something? We want to track the urine output, right? Look back to that classification, that shock, the chemovolemic shock class. Wow, I can't talk. You know that table I told you to know, right? The one thing that was consistent is if you have low urine or no urine, the more likely the class of shock is higher. Okay? So if you know your urine output, and this is one way that, you know, I have actually stood next to a nurse and been like, okay, it's been an hour, what is it? Okay, it's been an hour, what is it? Because I really need to know, do I need to go up or down on their fluid resuscitation? Okay? That's being judicial. Alright. Electrolyte disorders. We're only going to talk about 2. Okay? This should all be review. So we're going to go through it pretty quickly. Okay? So, we're going to talk about sodium first. Normal range of sodium concentration is 135 to 145. That's where our body likes it, that's where we're happy. Okay? Serum sodium reflects relative amounts of sodium in water. Okay, it does not measure the total body sodium. There's different things. We're only checking for, remember there's sodium in the urine, there's sodium otherwise, but serum sodium is what we're normally checking. Okay? So, when we have low sodium, hyponatremia, less than 135. Okay? There's mild, moderate, severe. Mild and moderate may actually be asymptomatic, especially if they are, if their main source of nutrients is, let's say, alcohol. Okay? They get their calories liquid. We've all known these people, right? We've all seen these patients. They're not necessarily eating normal nutrition, they're just drinking them. Okay? They may live with a sodium of 120. That's their normal. Okay, doesn't mean that they're not hyponatremic, but they may not have any awareness of it. They just may be functioning at 120. Okay, but you and I are somewhere between 130 and 145. If we were to drop to 120, we would be extremely confused. We would be not doing well. Okay, so hyponatremia really reflects water imbalance versus sodium. Okay. Most common electrolyte abnormality because we've given too much fluid. Okay, so remember when I said we were just liberally giving people fluid, liters a day, we weren't tracking that. We were causing people to be hyponatremic and causing complications because we gave them too much fluid. We dropped their concentration. Not that we gave them too much sodium, we just too much fluid. Okay. This is a good reference to try to differentiate the two, okay? Whether it's isotonic hyponatremia, so your fluid is actually normal but you're low sodium, hypotonic hyponatremia, okay? Or hypertonic hyponatremia. We're not going to get into all of those different ones. You've already had that with endo, okay? We're mostly looking at the hypovolemic ones versus hypervolemic ones, okay? So this is just a good chart to go over that. So, what are the signs and symptoms of hyponatremia? Okay? Again, maybe asymptomatic, but mainly you're going to start seeing neurologic type differences, okay? They may have gait disturbances, they may fall. You may actually find it in people who just have a fracture because they fell, okay? You may have nausea, malaise, headaches, lethargy, disorientation. They may be just confused. Okay, they may look like they're demented, but they're not. They're just hyponatremic. Okay? If they have a hyponatremia greater than 120 or it has a rapid decrease, okay, say that the alcoholic, is normally at 125 on a normal basis, but we gave them too much fluid because they didn't really disclose that they were an alcoholic, and now we dropped them to 115 very quickly, we're going to see this. Okay? So that's when you have seizures, coma, death involved. This is the one that we actually can give that hypertonic solution in a very small amount to try to bump them up outside of this threshold and then go slow to correct the rest of the way. Okay? So, we want to know new medications. There are many medications that can cause your sodium to decrease. Okay? Many new medications that can actually make you hold on to fluid. Okay? That chronic alcohol abuse, changes in fluid and solute state, so people, new diabetics, you may see this. Okay? Because they're drinking. They can't satisfy their thirst because their sugars are so high. Okay? And then changes in fluid output, again with the vomiting, diarrhea, NG losses, okay, can decrease or can change that fluid shift. They may be, their volume status may be low volume, normal volume, or hypervolume. It just depends, okay? We really want to look at if their mucous membranes are dry, do they have skin trigger, what's their IVC fluid like, okay? And then laboratory assessment, this is where you get the serum electrolytes, the sodium, or the urine electrolytes. We may want to get their osmolality. See actually how concentrated is that urine, okay? Because that'll tell us, well, the urine's super concentrated. That means the body's trying to keep the fluid in, okay? That it kind of leads us to where we're going. And also thyroid and adrenal function, again with that huge long pathway, we might want to, if we can't figure out why they're hyponatremic, we may want to look at their sodium or their thyroid and their adrenal function as well. But that's not normally an initial lab. Okay? So what do we do to treat it? If it's symptomatic or severe, we always hospitalize these people. Always hospitalize. Okay? We wanna get a nephrology consultation, so what's the difference between urology and nephrology?
Cut. Kidney versus nerves.
Okay, urology, surgeon,
Cut.
they cut. Okay, they do the procedures. Okay, nephrology are the medical kidney doctors. They're the ones who prescribe dialysis. Okay, so surgery versus medical, urology, nephrology. I would expect a question like that on the test when we get to the uro questions. But anyway, so nephrology, we want the kidney medical doctors to take a look at them to figure out what could be possibly going wrong in their kidneys. Okay, we want to monitor their fluid balance and weight, so daily weights, maybe putting them on a urine or a Foley. Okay, getting strict ins and outs, meaning I'm going to have that nurse actually measure how much fluid is going into their body. Okay, they get a liter or however many, 250 milliliters of water every so often. I really want to know how much goes in and how much comes out. Okay, if they're in an acute seizure, we get 100 milliliters of 3% hypertonic saline infused every 10 minutes. The goal is just to get symptom reversal, get them out of that seizure. We're not correcting the sodium, we're just getting them out of that seizure so that we can then correct slowly. If we correct too fast, we're going to demyelinate their brain and they're going to die. Okay? So slow is better, okay? This is why they require hospitalization. We're going to goal rate correct 4 to 6 milliequivalents per liter every day. Okay? So if they're at 115, how many days is it going to take them to get back to 135? Quite a few days, right? Very slow reversal. Okay, but at first, if they're in an acute seizure, we got to give them that 30% to hopefully get them out of that critical zone enough so that we can stop the seizure. Okay. Hyponatremia, again, urine output is one of the best indicators. Fluid replacement, or water replacement, there is such a thing as a free water deficit, okay? That's really more used for in critical care. I'm not gonna necessarily expect you guys to be able to calculate a free water deficit, but when we have somebody who we are hypervolemic, okay, we may need to pull back on the fluid. So we treat with fluid free water restriction, okay, because we're trying to decrease the amount of fluid to increase the concentration of their sodium. Okay, so we're increasing or decreasing the amount of fluid intake so that it increases the concentration. Okay, so we're making them dehydrated-ish. Trying to find that happy medium again of concentration to fluid. Does that make sense? Okay. All right, now, hypernatremia. You're above 145, okay? A lot of times, this is from a hyperosmolality, okay? Meaning that we have fluid losses, so your concentration is high. A lot of times we see this with diabetes insipidus, or we have burns, GI losses, they're vomiting, diarrhea, that kind of thing, okay? High osmolality, they may be very, very thirsty, and or they have an ADH type of issue, and so they're not necessarily sweating, they're not producing enough urine, they're just overloaded. But their problem is they don't have enough water. It's a very convoluted thing. They're dehydrated. Okay? Can be very complicated. All right. Now, lethargy, irritability, weakness, hyperthermia comes into play now. Okay? But delirium and seizures. Unless you do labs, sometimes you don't know whether they're hypo or hypernatremic. Okay, so getting those urine lights, getting those serum lights and the osmolality is really what you need to do in order to figure out where they are in this spectrum. Okay? May be delayed. They may be asymptomatic. okay? If they have a sodium over 158, that equals severe hypernatremia, okay? Normally, if your osmolarity, okay, so normal osmolarity is between 275 and 295. Okay, so if you're at 320 to 330, you're going to be pretty somnolent and confused, so very sleepy. Okay, if you're between 340 and 350, you're most likely in a coma, respiratory arrest, and death, on death, like doorstep. Okay, so getting that osmolarity is extremely important to know where they are on the spectrum. Okay, so if their osmolarity is greater than 400, okay, you either have non-renal losses or renal losses. Okay, you have to figure out what. Okay. Most of the time, if you have renal losses, you either have like very high glucose in your urine. Okay, so you're diabetics, you're undiagnosed diabetics, or you're very uncontrolled diabetics. Okay. If your osmolarity is less than 250, okay, you have very high sodium with dilute urine. Okay, so your body serum sodium is very, very high, but your urine is very dilute, meaning your body is pushing fluid into the urine. Okay, normally happens in two ways. Okay, two normal ways: central DI or neurogenic DI. Okay, diabetes insipidus. We see this a lot with head injuries. Okay, 1 minute they'll be fine, and the next minute they're putting out a liter of urine a day, or an hour. Okay, if you have a normal urine output of 50, and then over the next couple hours they go to 500, 600 milliliters an hour, you're most likely in a DI type of process. Okay? So, this is where knowing what the free water deficits are and replacing that free water. Okay, we're trying to give them back the water to decrease that concentration. So to dilute them. Okay, oral is best, but if you have to, give a hypotonic solution, right? Both LR and both NS have a higher concentration of sodium. So if they already have a high concentration of sodium, you don't want to give them more sodium. Okay, so do half normal sodium. Do 0.45 sodium chloride. That makes sense? You're still giving them fluid, but it's got less sodium in it. Okay? Or you can give them D5W, or dextrose 5% water. That is a type of fluid. Okay? Again, you gotta go slow. There's a common theme with neutremias. Okay, you go slow correcting. Otherwise, you can get, if you rapidly correct hypernatremia, you're gonna get cerebral edema and either have severe neurological impairment and or demyelination and death. So go slow in either of these when you're correcting. Okay, when we are talking about types of fluid, okay, or it really depends on what type of bulimia they're in. Okay, so this is where knowing their osmolality is really important. Okay, so if they're hypovolemic, we want to give them hypotonic solution, hypotonic fluids. Okay, if they're euvolemic, that's when we do the D5 half or the D5 water. Okay, and if they're hypervolemic, we want to give dialysis. We can give the D5W, but this most likely will need some sort of dialysis to try to filter out their blood. Okay? So that was a lot. How are we doing? Any questions on neutremias? Hopefully a little bit review. Yeah? I know it's not necessarily surgery, but these are very common surgical complications that we deal with on a daily basis. Because we either give too much or too little fluid or whatever. Okay? All right. severe hyponatremias. Initially, we want to give the hypertonic solution, but again, free water deficit. Okay, I will not make you. There's already other calculations that I'm going to have you do free water deficits. Just know that it exists. Okay, you have to know your deficit of free water in order to know how much water you need them to drink to correct. Okay. And then for chronic hypernatremia, again, we don't want to try to exceed more than 10 milliequivalents of correction a day. So for hyponatremia, 4 to 6, hyper, no more than 10. Okay, so go slow. Okay, we want to measure that urine output, we want to measure that water replacement, just like, am I going backwards? No. Okay. So basically, in a post-op patient, when the urine output is decreased and they have a high sodium, we want to treat with fluids, not diuretics. Okay? Because we did it to them, we didn't resuscitate them enough during the surgery. Okay? Alright, moving on to potassium. The kalemias, if you will. Okay? This should be easier. It doesn't necessarily have to do with bulimic statuses, so it's not as hard. Normal potassium is 4. Okay, so hypokalemia is less than 4. If it's 3.9, probably fine, unless they're in an ileus. Then we'll give like 10 milliequivalents of repletion. Okay, but we probably are all on a spectrum between 3.6 and 4.2-ish. Okay, but people who are in an ileus, we try to get to 4. That's what our body wants. Okay, to really work efficiently. Normally we see decreases of K with vomiting, diarrhea. If we have somebody on a diuretic, okay, what's our diuretic that loses K, loses potassium? Furosemide, right? So if you have somebody who's on a furosemide pill or furosemide medication and they're very hypokalemic, we may need to stop that and put them on a potassium sparing, which would be spironolactone. Okay? Why do we care? Why do we care what their pH, their potassium is? Arrhythmias, right? People can die. Okay? They decrease, so low K, their muscles don't contract correctly, especially your cardiac muscle. Kind of need that to live. Okay? We can also get diaphragmatic paralysis. Okay, muscles don't work right. Those are 2 muscles that are really essential to, life-sustaining things, breathing and the heart. Right? Yes.
Kind of important.
I see some smiles. Somebody got through. Okay. So when we look at an EKG, okay, so if you have somebody who has a hypokalemic presentation, you should always get an EKG. Always. Okay. And I'll say that again for hyperkalemic. If there's something wrong with your K, just get an EKG. If it's not 4, get an EKG. Okay? Because if it's low, you're going to see flattened T waves or inverted T waves. Okay? You may even see a U wave if it's really bad. Okay? Now, when we are giving repletion, this is why we also get magnesium. Okay? Because if your magnesium is low and we do not replete your magnesium along with your potassium, or potassium is probably not going to move. Okay? They are symbiotic. They like to be aligned correctly. So if you're hypomagnesic, okay, and you just try to treat the potassium, you're probably not going to go anywhere. So you have to treat both. You have to replete both. Okay? Alright, hyperkalemia. Most of the time we see this with renal insufficiencies, so your chronic kidney diseases. Okay, your AKIs. Why? This is why we care. That's why we went through all of those things about AKIs. Okay? normally if I see a hyperkalemic greater than like 5, I automatically retest. Okay? Why? Lab error, but what is that lab error? Hemolysis, right. Okay, so if you have cell breakdown before they run it, all of that potassium that's inside the cell just burst open, and now you have an artificial blood sample that has a high K. Okay, because all that K that's inside the cell is now outside the cell because the cell burst. That's why that's important. That's why I went over it in the first place. Okay? So if you think that, well, you know, the EKG looks fine, I'm not necessarily sure if this is true or not, before you give the treatment, just repeat it. Okay? Now, if your K is, 6 and your EKGs have very peak T waves, most likely you have a true hyperkalemic and you have to treat it. I would not wait for a lab result back in order to treat. Okay, if you have 2 things that confirm hyperkalemic, I would just treat. Okay, now how do you treat?
Calcium gluconate.
Always first calcium gluconate. Why?
Stabilize.
Stabilize the cardiac membrane. Very good, very good. Okay, so calcium gluconate first, and then follow it up with your regular insulin and your bolus of glucose. Okay, you want to do regular insulin, not any other short-acting or fast or long-acting. It's just regular insulin, and then 50, like basically an amp of D50. Okay, now if you really are not seeing much of a change, you can give albuterol. That does push K back into the cell. Okay, but normally with calcium, dextrose, and insulin, I at least see a change. I very rarely have to give albuterol, but we can. What's another way to decrease potassium?
Furosemide.
Sure, we could give furosemide, but if they're already volume depleted, probably not what you want to do. Is there a drug that could potentially be given orally that helps poop it out? Okay, excellent. Very good. So that is someone who has a chronic elevated potassium. It's not necessarily giving a lot of, you're not in this medical emergency type deal, but you just can't bring it down. A daily capsulate. Or you have somebody who's on a spironolactone and we can't get them off of spironolactone because we put them on furosemide and their potassium just tanks, right? So we need some sort of diuretic. We give K-Exolate along with it, and it evens it out. Okay? Any questions on potassium? Great. Where are we? Okay. Which metabolic disorder is often associated with hypokalemic? Who wants 1, 2, 3, 4. You is. Good. Okay. Liquid nutrition. Now, I know we have like 20 more slides. I really want to get through the slide deck. So if you guys really want to get done in 10 minutes, let me know. Or we could potentially just push through real quick to catch up. Let me know. Yell out if you don't like it. Liquid nutrition. Okay, so when we have people who can't necessarily eat orally, or we have people who are in that periop, stage, right, or they're post-op and they're not awake yet. Okay, they're in a coma, they're have a head injury, and we can't necessarily, or they've had a stroke and they just physically can't eat because their swallowing mechanism is not there, right? How do we feed these people? Okay, we need to make sure that it meets the metabolic demand. Okay, so we need to measure their normal basal metabolic rate, and we increase it because of insensible losses in critical ill patients, okay? Normally, we can keep people off of food for about a week, but once it gets to that 7-day mark, we really need to start thinking about what are we gonna do to feed these people, okay? Enteral, okay, we can put in an NG tube, we can put in an OG tube, or an oral, so nasal gastric tube or an oral gastric tube. Okay, we can put in a Dobhoff tube, which is, it goes in the nose, but it's softer, it's smaller. Okay, it's not necessarily made for sucking fluids out like an NG tube, but it's very good for getting, liquid food down. We can put in a PEG, a G tube, or a gastric tube, or a genostomy tube. Okay, PEG, G, and J tubes are all surgical. Okay, all the rest of them can be placed by you guys. When we talk about peripheral parenteral nutrition or total parenteral nutrition, normally when we talk about TPN or total, it has to go through a central line. Our peripheral veins don't really like it. Okay, if we're doing it for a very short time while a central line is being placed, then we can do it. But most of the time, if we only need it for a very, very short amount of time, we can do peripheral. Okay, so different types of concentrations of food. Okay, this is why we have nutritionists and dietitians in the hospital to do this math for you. Okay, they will meet with the patient and measure their metabolic rate and tell us or tell me, okay, they need this type of fluid, they need that type of fluid. Okay, so when it says enteral, means they're using their gut. Okay, if it's parenteral, using their veins. Okay, so if they have a surgical patient and their intestines are what we call in discontinuity, means that they're not in line with, mouth to anus. There's a part that's in discontinuity. We cannot use their gut to feed them. Okay, so we have to use their veins. There's complications to that. But, enteral, so this is NG tube, OG tubes, PEGs, G tubes, and J tubes. Okay. Must have a functioning GI tract. It's the biggest thing. Okay. Now, there's one other reason why we would do this. Say that there's a patient who is demented and they can't actually eat on their own because they just forgot how, or they're, like I said, they have had a stroke and their swallowing mechanism is just not there, their reflex is not there, but they still can digest. Then we'll put a tube in and feed them via the tube. Okay. All right, total parenteral nutrition. This is through the veins. Okay, this is normally again managed by a multidisciplinary team. You have the dietitian, the pharmacy, and then if it's TPN, normally through a central line. Okay. Daily electrolytes. So if you have somebody who is severely malnourished, okay, their albumin's less than 3, their pure albumin's less than 16, okay, especially if their albumin is less than 3, that chronic malnourished, okay, we have to check potassium, magnesium, and phosphate. Okay, there is such a thing as refeeding syndrome. Once the gut starts getting food, it'll actually cause a severe drop in their phosphate. Okay, I know we didn't go over phosphate, but it basically is an increase in insulin because their body's finally getting food, and it just severely drops. Okay, so we get daily electrolytes for severe malnutrition, or just weekly electrolytes, their liver, or their lipid panel, and their liver function. Okay. All right, vascular. This will go pretty quick. So we have peripheral IVs, we have interosseous IVs, central lines, and art lines. Okay. Is any of this new? No. Great. Okay. Vascular access. Depending on what we need it for. Okay, if we're doing CT scans, We want it at least 20 or higher, 20 gauge or higher, okay, or larger, really. Okay, we want it in a peripheral vein, antecubital fossa forearm hand. If it's going to be in for a long time, the ACs are not that great, okay, because you want people to still move and not have it kink. So we may do a forearm or a hand if we need to, if it's going to be in there for a long time. Okay. If you see an order that says KVO, it just means keep vein open. TKO, same thing, to keep open. You're not going to be on an actual maintenance rate. You're only going to be like 10 mLs an hour just to keep the line open and not clotted. Okay, so it's not enough to actually maintenance them or keep them hydrated, but it's just enough to keep the line open. Okay? We have heparin locks and saline locks. No fluids are actually running, but their IV is actually still in place. If it's a longer line, we may instill it with a little bit of heparin to keep it from clotting off inside. So when we have our peripherally inserted central lines or PICs, if we're not using it for a time, we'll instill it with a heparin solution so that it doesn't clot off. Okay? And then we do have the ability to do saphenous vein cut downs. As primary care PAs, this is not something you're necessarily going to be taught. If you ever deploy, your surgeon may teach you. Okay, but this is something that's a pretty decent skill to have, but unfortunately we do not teach it in this program. Okay, interosseous infusions, so easy IOs. Who's placed an IO before? A few of you. Kind of interesting, right? You will be able to all do an IO when we do our ATM lab. So be forewarned. These are for people who have collapsible veins, right? So we're trying to do it, we're trying to get fluid into the medullary space of the long bone. Okay, so we normally use either the humerus or the tibia. There's a couple different places we could also do the iliac crest, but that's a little bit more difficult. Historically, especially with TCCC, we do the sternum. I hate the sternum because if they lose pulses and we have to do CPR, I'm not doing CPR on someone who has a sternal IO, right? That's a long ass needle into the sternum, very, very close proximity to the heart. Probably not great, right? So I will never do a sternal IO, but they do make them. In terms of locations, we'll more so go over that with the ATM lab, okay? Just know that we use those for, they're non-collapsible veins within the medullary sinuses, and it's only a bridge, right? We don't necessarily recommend it longer than 24 hours. This is the acute phase. They are acutely crashing. We're trying to get fluid into them to resuscitate them while we get a central line, while we get a cordis. Okay, once we have that cordis, that IO is no longer needed. We can take it out. Only one contraindication to IOs. Okay, only one. Nope. Open or just fractures in general, right? If your humerus is fractured and that medullary sinus is open, is it gonna do anything? That fluid that we instill into that fractured bone is just going to pool inside your bicep and not actually get into your intravascular space. So if you have a fracture in that bone, you cannot use it, okay? The only other caveat to that is we try not to put it into a cellulitic process, okay? Absolute contraindication is fracture. A contraindication, or just a normal contraindication is cellulitic process over the site. Okay? All right, central line, so we have the cordis versus triple lumen. Cordis is a single lumen. It is very big. We can instill a lot of fluid within a very quick amount of time. Okay? A triple lumen is a smaller tube that has 3 smaller tubes within it. Okay? So if you have a sepsis patient and we need to give fluids, antibiotics, and pressors, a triple lumen is great. Right? We can use that to instill 3 medications into one line. If we have someone that we are resuscitating with blood, we want a cordis. We want that single lumen, large bore into the central veins, okay, to give a lot of fluid very, very quickly. Okay? Now, depending on where you put it, increases your complication rate. If you put it in your jugulars and or subclavians, you're gonna, your pneumothorax is your number one complication, okay, because it's very close to your thorax. You don't want to cause a collapsed lung. You can accidentally hit your artery. Okay, I've heard of people putting your cordis into the carotid artery. Not recommended. Okay, and then catheter-related sepsis. Okay. Normally, especially in trauma, when we're putting in these cortices, it's a very dirty line. Okay, we try to splash a little bit of betadine, but realistically, they're life over infection. Okay, so we try to, if we get them back, we will change out these lines very, very quickly in a more sterile process once the threat to their life is over. Okay, so yeah. Okay, central lines, the three main places that we normally do them: subclavian, internal jugular, and femoral. Okay, we can do it at the external jugulars and the cephalic veins, but the three most common are subclavian, internal, and femoral. Okay, Selinger technique, that's a 9-minute video, we're not gonna watch that, you guys can watch that on your own. So Selinger technique is basically just the way that we introduce something over a wire. Okay, so it could be putting in a chest tube over a wire, it could be intubation over a wire, it could be putting in a line over a wire. That's all that means. Okay, the most commonly thing we do are those three things. Okay, so if you want to learn more about the Selinger technique, you can watch that video. Okay, peripherally inserted central lines, PICCs. Okay, these are longer central lines. They're still large bore. They can have multiple lumens, but we normally put them in the cephalic. Okay, but then it ends in your superior vena cava. Okay, so it's still a central line, still comes up to where we need it to, but it's inserted peripherally. You have to be specially trained to do that. I'm not even specially trained to do a PICC. Okay, normally your hospitals will have a PICC team or a line team, normally nurses, who come around. If you want one, you have to just consult them and they'll put one in for you. Okay? We need these in for a long time. So these are your people who are chronically malnourished and they need TPN, or they need chronic, like 6 weeks of antibiotics, of IV antibiotics, right? So chronically placed, or a long time placed line, but infections, breaks, air embolisms if they're not used correctly, and then thrombosis, clotting off of them is a big complication that we have. Okay, art lines, there's two main places that we put them. We have the radial artery and the femoral artery. Okay, when we put them in the radial artery, what's the one thing we need to do before we place it?
Allen's test.
Allen's test. Anybody want to explain what an Allen's test is?
Radials and the ulnar artery, and let the ulnar artery go and make sure it's still the spot.
Yes. So you guys can all do this on your own. Okay. Basically, you close off both your radial and your ulnar artery. Okay. You'll see. I'm gonna put my hand a little bit. My palm goes white. Okay. Now, if I'm putting a line into my radial artery, I need to simulate a clot in my radial artery, right? Because if you put something in an artery, you need to make sure that if it clots, it still has the ability to reperfuse via the other way. So you lift your finger, your ulnar artery, and if your palm gets back to being pink, your ulnar artery is intact and patent. That means you can put a line in your radial artery and accept the risk of a clot in that radial artery because you have the ability to get backflow from the ulnar. Okay? If that doesn't happen, you do not use that hand. Okay? If you don't have any backflow from your ulnar artery for whatever reason, you don't want to take out your radial because your radial is the only thing supplying blood to your palm. Okay? If you take out both, you're going to have a critical lane ischemia and a very pissed off vascular surgeon. So don't do that. Okay, so Allen's test, very, very common. Axillary artery, not that common. I don't think I've ever seen one because we'll place a femoral if we need it. Now, the main reasons why we put these are continuous atrial pressure monitoring, arterial pressure monitoring, so we need invasive blood pressures, okay, very, very sick people, actively, resuscitation, okay, I really wanna know what their maps are, I really wanna know like what their internal blood pressure is, because their, blood pressure cuff, like I said before, isn't necessarily the greatest measurement. Or if we have someone we need those EVGs from, okay? They have ARDS, they have some sort of respiratory disorder, okay, that we are chronically or every hour needing to check an EVG, okay? Instead of having to poke them every single hour, these are not painful tests, right? If you were to poke your artery, it's painful. Okay, so if we need to check your EVGs a lot, we'll just put it in our line and take the blood from that line versus poking you every hour, trying to figure out, what we need to do on your vent settings. Okay, we can also connect it to that transducer. Okay, that gives us that nice art line, and we can also hook this up to the flow track or the Vigileo, like I said, to get that internal monitoring. Okay, we do not put anything in the art line. No blood, no fluids, no medications, nothing goes in this line. We only take from this line. Okay? Alright. Where are we?
Past due, waiting on you.
How many more slides do we have?
Five slides?
8 slides, 7 slides.
Do you want to keep going, or do you want to take a break? Just go.
We have the after lunch too, so.
I know, but we have a longer slide deck this afternoon. Okay, we'll do these real quick. So implantable port. Okay, these are normally for chemo and or long-term TPN. Okay, it's a surgical procedure. A surgeon will go in, implant in a little port, and then a line goes into their subclavian. Okay, normally we place these under fluoral or CT guidance, like IR will place these, the surgeon will place these, okay? But you really have to have something that you need to be, like, say they need an iron infusion because they're chronically, like, and this is every month, it's just something that lives with them until they no longer need it. Okay, E-tubes, so nasogastric tubes, internal, feeding, and then TPN, watching for the repeating syndrome. I don't think so the other reason for nasogastric tubes, like I said, decompress the stomach. So we'll put an NG tube in, and or an OG tube, anybody who goes to surgery, anesthesiology will do this after you're asleep. Okay, so that if they need to, they can decompress the stomach, or if we're actually working on the stomach, they can instill air into it, and we can actually then see where the belly is or see bubbles, okay, if we're looking for a hole in the stomach. Okay, so it's pretty nifty that we can use this. NGOG, interchangeable for feeding tube versus decompression. Now this is a big one. For anything that goes into the stomach and we are sucking things out, low wall intermittent. Low intermittent. Okay, you do not want this continuous, and you do not want it any higher than low. Okay, why do you think that is?
Because got the wall ischemia and stuff, it sets up against the stomach.
Yeah, so if it's continuous, right, and it sucks up the wall of the stomach, you're gonna get an ulcer, and it could potentially erode and cause a perforation. So if it's constantly letting go of that pressure, it has that chance of it not actually sucking up the wall and causing an ulcer. Okay. Anybody who has post-op vomiting, nauseousness, or like prolonged, then we're expecting them to have an ileus. We'll put this down to help relieve those symptoms, and we won't take it out until they start passing gas or having a bowel movement. Okay. They don't like it. So radiopaque tip, those are mainly for, so every NG tube has a radiopaque line that shows up on x-ray. Okay, so if you place an NG tube, you get a chest x-ray. Okay, you want to make sure that it goes down and not up or over. Okay, I've seen it being placed in the lungs. I have yet to see it being placed in the face or into the skull, but it has happened. Okay, if you have a cribriform plate injury, okay, nothing goes in the nose if you have a suspected basilar skull fracture or a cribriform plate fracture, okay, because then it can actually go through that fracture and up instead of down, okay. Knowing what those complications are, so the stomach injury, and then if we take too much and we're bleeding, it can cause that hypokalemic, okay, that acidosis because we're taking too much of their fluid off. So you just need to know and make sure we're correcting and or repleting that potassium and fluid. Okay, duodenal and jejunal type nasogastric tubes. So this is really going to be the Dopphoff. Okay, the Dopphoff is weighted at the end, and we can actually get it through the pylorus. Okay, so it's past pylorus, post pyloric. So say we did surgery on the stomach, and we don't want any food to touch the stomach, we can put the Dopphoff in and actually have it go past the stomach and feed the rest of the gut while not having any food touch where we repaired. Or other way around. Okay. We always have to get another chest X-ray or even a KUB, a kidney, ureter, bladder X-ray. That's basically an abdominal series X-ray to make sure that it's past the stomach. Okay. We can get it further with jejunal. These things are pretty long, and so if we did a lot of surgery within their duodenum, we can try to get it past that loop and back over on the other side of their belly. And again, we'll see that on X-ray if we've gotten there. Okay. A lot of times we will place these intra-op, and so we know that the tip is past our surgical spot. We'll actually feel it and keep telling the anesthesiologist to like, hey, keep going, and help feed it to where we want it to end through the intestines. That make sense? Okay. G-tubes, okay, these are surgically placed. We can either do a PEG, so percutaneously, or we can do an open gastrotomy tube, okay? One uses an endoscopic approach, meaning through the mouth. Okay, the other one is we open up once we're already in the belly, we'll kind of make tack the stomach up to the skin and place the tube through the skin, okay, before we close. We can also do this for junostomy tubes as well, okay? If we have the belly already open, we're gonna find that jejunum and place the tube there and tack it to the side wall of the abdominal wall, so it doesn't move, okay? These are people who have, say they've had a Whipple, right? And they're not gonna be using their stomach and or part of their, they don't want to use the first part of their intestines until that entire surgery heals. Then we can place a jejunostomy tube that's lower down, okay? That kind of thing. Okay. 64-year-old male develops supraventricular arrhythmias after undergoing open heart surgery. Laboratory measurements indicated potassium levels 6.7. After administering calcium, what's the next step? Who wants 3? Yes. 3, right. Insulin and glucose. What else do you want to do? Before you even give calcium, what do you want to do? Get an EKG, right? If you have peak T waves and a K of 6.7, you can almost guarantee that it's correct. If you don't have peak T waves, what do you want to do? Repeat that lab. Good. Okay. This is someone who is a very sick patient. You can see that they have a head injury with the wrap and blood on their head. They have a seat collar on. Okay. When we are in critical care and or when we're transporting these people, you have to be aware that all these things exist. Okay, that's why we go over it. She has an NG tube in her nose. She has an ET tube in their mouth. I don't know if this is a female or male, sorry. They have the ICP monitor on their head. Okay, intracranial pressure monitor. We'll go through that with the head injury, the brain lecture in a few months. Pulse ox, fluid levels, everything, right? So knowing what all these, when you get to the ICU, right, you're not going to see this type of patient on the floor. Hopefully not. These patients are in the ICU. Okay, they're most likely in a chemically induced coma. Okay, knowing what all of the tubes are is extremely important. Alright? So if you don't know, ask. Alright. Go to lunch. I'll see you at 1?